What's up everybody, Dr. Rossi, shrinksandSneakers.com. In case you're new to the channel, I'm a board certified psychiatrist who talks about all things related to psychiatric practice, including diagnosis and medication management. So if you're new, please consider subscribing to the channel. And if you haven't done so already, I'm going to ask you to go ahead and subscribe to the channel so that you can get updated information released every week on Monday. So with that said, I'm going to crack right into the topic this week because it's an excellent one. It's one I get asked about all the time. And that is bipolar disorder versus borderline personality disorder. How easy is it to distinguish or tell the difference between these two disorders? And I'm going to take a completely different approach to what you guys are used to hearing. And I think you're going to really like this content. So this may be one of the most common questions that I get either from people commenting in the videos or in general in practice. And that is, people really struggle with the distinction between bipolar disorder and borderline personality disorder. Some even say that bipolar disorder is overdiagnosed, while some other people will tell you borderline personality disorder is overdiagnosed. And usually each of those people will cite the other disorder as the one that should have been diagnosed. So for example, if somebody says borderline personality disorder is overdiagnosed, they'll say that bipolar disorder was actually the correct diagnosis. Who's to say who's really right here, but hopefully we can help you guys clarify that in this video. Now, personally, I don't love the term personality disorder. It's an antiquated term, it's an old term, it's all the way back to DSM-3, which, at this point is very outdated. So I prefer to talk more about personality traits and temperament from a dimensional framework, but that's a topic for another day and a little too much depth to get into here. So keeping in mind a theme that I talked about in the last video, we're moving away from DSM-5 terminology and concepts, and what I'm going to say here is completely different than what you've learned elsewhere. And if you recall from the last video, I said that there were diagnostic validators of all psychiatric disorders, and those are symptoms, genetics, the course of illness, the response to treatment, and of course, the biomarkers that don't exist in psychiatry. With that in mind, let's first break down the diagnostic criteria for borderline personality disorder and do it in a different manner than you've ever seen anywhere else. So the DSM-5 kind of breaks down borderline personality disorder into like a dictionary format. So we're all using the same language for the diagnostic criteria. And that means that when I talk about borderline personality disorder, somebody else who's read the criteria will also know what I'm talking about. But let's break it down a little bit further than that. Let's look at the criteria and break them down into the ones that are Freudian in nature, so psychoanalytic based diagnostic criteria of borderline personality disorder. Let's look at the ones that overlap with mood disorders, such as bipolar disorder or major depressive disorder. And then let's look at the couple of individual ones that are really distinct for borderline personality disorder. And that's how I'm going to break it down for you guys here. So the three criteria that are Freudian in nature and really not well established empirically in the literature are, number one, chronic feelings of emptiness, number two, unstable self-image, and number three, efforts to avoid real or perceived abandonment. Again, these are criteria for borderline personality disorder, but they're more Freudian in nature, more psychoanalytic, and not really well established in the research literature base. The other criteria we have trouble with because they overlap with mood disorders. So if you're trying to distinguish bipolar disorder from borderline personality disorder, you're going to struggle when you see these next three criteria. And those are, number one, impulsivity. So impulsivity is common in both borderline personality disorder as well as bipolar disorder. Number two, anger or rage. You could see anger or rage in either of these disorders as well, so that's not going to really help you make a diagnosis or create a treatment plan for that person. And number three is affective instability. So again, affective instability, you can kind of think about this by breaking it down by frequency and severity of affective dysregulation, but even that's not enough to really distinguish the two. They overlap with each other. So again, it's going to be hard to look at impulsivity, anger, rage, and affective instability as the sole ways of distinguishing borderline personality disorder from bipolar disorder. Now, the two that I love to focus on because I think they're really distinct and they're really well validated in the research literature for borderline personality disorder are number 1, recurrent suicidal behavior or self-injury. And I'm going to explain more about why this one is so well established and what distinguishes it from bipolar disorder. And number 2 are transient states of paranoia or psychosis. So the transient states of paranoia or psychosis are kind of unique to borderline personality disorder. And then there's one that's not in the diagnostic criteria at all, but definitely should be, and I'm going to tell you why in a little bit. And that is a history of trauma, specifically a history of sexual abuse. It's very common in borderline personality disorder and really should be part of the core definition of BPD. So let's break each of these down a little bit deeper so that you have a better understanding of what we're talking about here. So let's talk about mood liability first. These are rapid alterations or fluctuations in mood over time, and they can often occur over minutes or hours. And you might be saying to me, Dr. Rossi, you must be talking about borderline personality disorder here if you're talking about changes in mood over minutes to hours. However, that's not entirely true, and this is very common in bipolar disorder as well. And the bottom line here is that even though we can look at the frequency, the intensity, and the duration, which can help us distinguish the mood changes in borderline personality disorder from bipolar disorder, it's common in both disorders, and it's not specific enough to make a diagnosis of one over the other. Impulsivity is another common factor found in both borderline personality disorder and bipolar disorder. So sexual impulsivity is common in both disorders, but you can also see things like physical, aggressive, or financial impulsivity as well. And like I said, it can occur in both disorders, so it's common to both conditions. It doesn't really help us distinguish the two. So I promised you guys that I would elaborate on the criteria that really help distinguish bipolar disorder from borderline personality disorder, and I'm going to talk first about parasuicidal behavior or self-injurious behavior. Now, people with borderline personality disorder are far more likely to engage in self-harm, and in fact, one study found that 50 to 80% of people with borderline personality disorder engaged in self-harm. And furthermore, 41% of those people had over 50 separate acts of self-harm. So this is very, very common in borderline personality disorder, and in fact, it's far more common than what you see in bipolar disorder. So it occurs frequently and consistently in people with borderline personality disorder, and it's not nearly as common as to find this in bipolar disorder, where things like completed suicide, not parasuicidal or self-injurious behavior, are more common. One of the best ways in my mind to distinguish these two disorders is to just find the presence of an acute manic episode, or to find evidence of mania, specifically mania that meets criteria for bipolar 1 or bipolar 2 disorder in the case of hypomania. So if you can find, let's just take mania as the example, that meets criteria for bipolar 1 disorder, then the person is not borderline, they're bipolar until proven otherwise. So if a person has had a full-blown manic episode, the diagnosis is bipolar disorder until proven otherwise. This will be the more important diagnosis to treat in the hierarchy of psychiatric treatment. So I don't really want to get into it here too deeply, but there's a hierarchy to which disorders you want to focus on first. And my clinical experience has taught me that first you would try to stabilize the person's mood and treat their bipolar illness, and see if these other symptoms that could just be, again, overlapping symptoms that appear to be borderline personality disorder are in fact just overlapping symptoms of bipolar disorder. And once the bipolar illness is treated appropriately, the person's other symptoms will resolve along with it. So I've talked a lot about genetics, and I said genetics is really important in a few psychiatric disorders, specifically those ones being schizophrenia, bipolar disorder, and Alzheimer's dementia. Now, when we look at bipolar disorder, it's highly heritable. So the estimated heritability is 80%. And like I said, this is similar to schizophrenia and Alzheimer's disease. And in my previous videos, I said that if a person has one or more first-degree relatives with bipolar disorder and they're seeing you as a psychiatrist, you want to think heavily about putting bipolar disorder in your differential diagnosis because of this heritability. Now, borderline personality disorder, on the other hand, is more environmental in terms of its cause. So what I mean by that, environmental factors are more likely to lead to the development of borderline personality disorder or personality disorders in general, And the heritability, although it's not zero, it's estimated to be about half of that, or 40% of heritability compared to bipolar disorder. So again, it's more environmental, 60% environmental factors leading to the development of personality disorders versus 40% heritability and genetics. I've also said throughout this video and other videos and other content that I've made elsewhere that sexual trauma is a major factor found in a majority of borderline personality disorder cases. Although this failed to make it into the diagnostic criteria in DSM-5 or DSM-5-TR, the revisions that have recently been released last week, the criteria is found in 50 to 76% of people with borderline personality disorder. So 50 to 76% of people with borderline personality disorder have a history of sexual abuse. And that's compared to only 30% of people with bipolar disorder. So yes, people with bipolar disorder do have a history of sexual abuse in some cases, but far more people with borderline personality disorder have a history of sexual abuse compared to those of bipolar disorder. A quick word here about treatment response. And in many cases, people with borderline personality disorder are on multiple medications. Some are on as many as 5 medications at a time, and they're still taking as needed medication in addition to those 5 standing medications. So people with borderline personality disorder often get over-medicated and medicated with inappropriate medications because the diagnosis simply isn't correct. Whenever I see this clinically, I immediately think, let's question the diagnosis. At least that's one thing that I'm thinking. Obviously, there's other factors like, has the person been on the medication long enough? Have they been titrated to an adequate dose? There's many factors, but one of the things I think about is somebody on a bunch of different medications may or may not have the correct diagnosis if they're not getting a response to all those different classes of meds. And the person's usually on a mood stabilizer, dopamine blocking medication, a monoamine-based antidepressant, and a benzodiazepine for good measure, and they're still symptomatic. You want to start thinking about borderline personality disorder or some other factor interfering, such as a substance use disorder, in these cases. And diagnosis is key. Just a quick word on diagnosis. Diagnosis is key when selecting medications because the clinical trials, when they work them, they're very careful about the people they select for the clinical trials. And they often will select people who have just a pure bipolar disorder, for example, no comorbidities, no substance use disorder. And obviously that's not very common in clinical practice in the real world. And if you have the incorrect diagnosis, then the medication is highly unlikely to work the way that it's supposed to because of the quality and selection of patients in clinical trials when they're approving these medications for use. All right, so let's wrap this thing here. To wrap it up, borderline personality disorder and bipolar disorder can be distinguished clinically, although it may not be using the standard DSM-5 criteria. Bipolar disorder is seen as a biological disease that's heavily influenced by genetics, and borderline personality disorder is related more to environmental factors and psychosocial stressors. The two are treated differently, which is important, with a strong emphasis on medication in bipolar disorder and a strong emphasis on psychotherapy in borderline personality disorder. You also want to be mindful of different types of temperaments, specifically hyperthymic and cyclothymic temperaments, which can complicate the picture and lead to an incorrect diagnosis. With that said, I'm going to hold the video there. Please drop your comments below. I'll be happy to answer them throughout the week. And let me know what additional content you guys want to see. Until next time, please subscribe to the channel and let's keep this thing going.